Demonstrating how to perform an auscultatory blood pressure. Care should be taken to obtain the appropriate size blood pressure cuff. This is done by measuring the patient's arm. The inflatable bladder within the cuff should have a width of about 40% of the upper arm circumference. The length of the bladder should be about 80% of the arm circumference. Notice the cuff placement. It is 2.5 centimeters above the antecubital fossa. The doctor is palpating the radial pulse. This is to establish the set point, which should be 30 millimeters mercury above the disappearance of the radial pulse. Once this point has been established, pressure should be released and the arm rested for 30 seconds before beginning the actual blood pressure. Notice the stethoscope placement. The bell is slightly medial because of the course of the brachial artery through the fossa. The blood pressure cuff is now being inflated to the set point and slowly released while listening for the cough sounds. The proper rate of deflation should be no faster than 2 to 3 millimeters mercury per second. The occurrence of the first sound is taken as the systolic blood pressure reading. The last sound heard is taken as the diastolic blood pressure reading. The cuff should continue to be deflated until the dial reads 0. When you are proficient with this skill, you can advance and establish a set point and take the blood pressure in one step. The demonstration of George's test. The first part of this test is the taking of a complete case history with the main focus on cardiovascular questions. Next, bilateral blood pressures are performed. A set point is done on the first arm. Once this has been established, the same set point is used on the other arm. The blood pressure readings should be within 10 millimeters mercury of one another, meaning there should be no more than 10 millimeter difference between the two systolic readings obtained or the two diastolic readings obtained. If a difference of more than 10 millimeters occurs, this is considered a positive test and no further steps should be done. Otherwise, with normal results, George's test is continued with our next step, which is auscultation of the arteries. All auscultation should be performed using the bell of the stethoscope. First, we auscultate the subclavian arteries. This artery is located in the supraclavicular fossa. To isolate or hear it better, the patient can be instructed to take a breath and hold it. Now the doctor is auscultating the carotid artery. The best place to hear this is at the bifurcation of the artery at approximately C6. Again, this is done bilaterally. You will be listening for bruits. If a bruit is heard, this is a positive test and no further testing is done. With all tests normal, palpation of the carotid arteries is done next. Palpation of the carotid arteries should always be done one at a time. You will be feeling for thrills. Again, if a thrill is felt, this is considered positive and no further testing should be done. With all tests being normal to this point, the last step is performed. This is Main's maneuver, or the vertebro-basilar artery function test. Before actually performing the test, the doctor will instruct the patient to notify her if she experiences dizziness, nausea, visual disturbances, or lightheadedness during the testing. The positioning of the head is critical. The patient is instructed to turn her head all the way to one side and point her chin towards the ceiling. This position provides maximum hyperextension, and this positioning should be held for 30 seconds. While performing the test, the doctor is observing for nystagmus. If at any time any of these signs or symptoms occur, the test should be stopped immediately. This would be considered a positive test and no further testing continued. The patient would be instructed to return her head to the neutral position. If all of the testing done in this procedure is normal, George's test is considered negative. The ear exam. The Hippie-Ronell format of examination is followed in this exam. A complete case history has been performed, asking pertinent questions concerning hearing difficulty, any pain, ringing, discharge, dizziness, history of ear infections, tubes inserted, or any medications that the patient is taking. All parts of this exam should be done bilaterally. After the case history, inspection is performed looking for any abnormalities, lesions, swelling, and symmetry. Next, palpation is performed. There are three main areas: the auricle, the tragus, and the mastoid. Both ears can be palpated simultaneously. Any irritation or pain should be noted and what area was involved. There is no percussion step when performing the ear exam. Instrumentation is performed next using the otoscope. A disposable tip is placed on the speculum with a slight twist to secure it in place. The doctor instructs the patient to tilt his head as the doctor gently displaces a hand on his head. The auricle should be pulled posterior, superior, and slightly out to allow for straightening of the canal and enable full inspection. The tip of the cone is then placed in the external auditory meatus. The handle can be held in either an up or down position. Again, this is done bilaterally. The doctor will be examining the canal and the tympanic membrane for inflammation, infection, color, integrity of the membrane, the cone of light, the handle and the arm of the malleus, and any pathological abnormalities. After instrumentation, the next two parts of the ear exam are performed. The Weber and Rene test are done to assess sound conduction. Weber is performed by placing the tuning fork on top of the head anywhere along the sagittal plane from the crown to the forehead. It should be rung fairly loud. Note the placement of the fork with the U facing anteriorly. When performing Weber's, the patient should be instructed to tell the examiner in which ear he hears a sound. Is it in both ears the same, or in one ear more than the other? If the sound is louder on one side, this is called lateralization. Next, the Rene test is done. This is always done no matter what the results are in the Weber test. During the first step, the doctor rings the fork slightly and places the base of the tuning fork on the mastoid, taking care not to touch the individual arms of the fork. When the patient notes that the sound has ceased, the doctor brings the fork to within 1 inch of the external auditory meatus and waits until the patient again reports cessation of the ringing. Note that the fork is not rung again between these two steps. The doctor will be timing both of the steps in this procedure. It is normal to hear the sound twice as long at the external auditory meatus, which is air conduction. This concludes the ear exam. The eye exam. The Hippie-Ronell format of examination is followed in this exam. A complete case history has been performed asking pertinent questions concerning vision. General questions would include the use of prescription lenses, changes in vision, double vision, pain, discharge or redness of the eyes, history of glaucoma, cataracts or eye surgery, and any other diseases or medications, as well as the date of the last eye exam. Inspection is performed next. This includes the brows and hair distribution, lids, pupil comparison, sclera, and cornea. You should be noting symmetry, changes in coloration, edema, nodules, lesions, and opacities. Palpation includes the periorbital rim, lacrimal apparatus, and gentle palpation of the globe as long as the patient is not wearing contact lenses. Note the change in order next. The neurological screening test will be performed prior to the more invasive fundoscopic exam. The visual field is done first. The examiner can either stand in front of or behind the patient. An object is slowly brought into the patient's field of vision from several directions, and the patient reports when he sees the object while he is focusing straight ahead. Accommodation can be done next. The examiner instructs the patient to look at an object about 15 feet away. Then the doctor will bring an object, a pen or a finger, into the patient's visual field about 15 inches from the eyes, instructing the patient to focus on the pen. The patient will then be instructed to look again at the far object. The doctor will be looking for a quick change in pupil size when the patient changes focus from the far object to the near object. This should be done on each eye individually. The cardinal points of gaze is done next, checking extraocular muscle function and assessment of the coordination of eye movement. The patient is directed to hold his head still and follow the doctor's finger or object with his eyes as the finger is moved. This is done about 12 or 15 inches in front of the patient, moving the object through the cardinal fields of gaze in an H pattern. The doctor should pause momentarily in the upper outer locations to observe for nystagmus. This will be screening the innervation of cranial nerves 3, 4, and 6 to the eye muscles. At the end of this step, the doctor can immediately check convergence. This is accomplished by asking the patient to watch the object as it is moved from directly in front of the eyes toward the bridge of the nose. The last procedure in this group is checking the direct and consensual response to light by the pupil. This response provides information about cranial nerves 2 and 3. The direct response is performed first. The pen light is first shined in the first eye, while the doctor observes for constriction of the pupil in that eye. The same procedure is now being done on the other eye. The consensual response is done by the doctor providing a light shield with her hand. Then the light is shined in one eye while observing for constriction in the other eye. When performing the last part of the eye exam, the ophthalmoscope is used to view the fundus. The instrument should be set at 0 diopters or the plano settings as the starting point. The last part of this exam begins with checking the red reflex. The patient is instructed to look straight ahead or over the doctor's shoulder. The doctor will stand approximately 15 degrees from the midline of the patient and from 15 inches away, shine the light in each eye, observing for the red reflex, noting any areas of opacities interrupting it. After observing the red reflex, the fundoscopic exam can be immediately done by bringing the ophthalmoscope to within 1 inch of the eye being examined. At this point, the ocular fundus is examined, observing the retina, optic disc, macula, and retinal vessels for any abnormalities. During this part of the exam, note the size, shape, clarity, and color of the disc and its margins. Also note the cup-to-disc ratio. When viewing the blood vessels, note the branching pattern, fullness, contour, and integrity of the vessels, the veins being dark red and 1/4 to 1/3 larger than the arteries. The macula should be lateral from the disc and be a homogeneous color slightly darker than the rest of the retina. With this complete, the doctor is now backing out of the eye by changing the diopter settings to view the vitreous fluid, lens, and cornea using the black or green diopter settings. Note that the ophthalmoscope is still about 1 inch from the eye and that the doctor has not moved herself. The other fundus is now being examined. Performance of a posterior thorax exam. Case history questions should include screening information concerning chronic cough, shortness of breath, history of wheezing, asthma and smoking, family history of lung diseases, breathing medications, and any other pulmonary problems. Inspection is performed next. Observe the rate, rhythm, depth, and effort of breathing. Observe for cyanosis in the fingernails and lips. Observe the shape of the posterior chest and its movement, looking for asymmetry, retractions, or impaired respiratory movement. Observe for any skin lesions. Palpation will include several steps. First, palpation is performed over the entire posterior chest for any tenderness or masses. This should be done in a pattern that compares symmetrical sides of the chest, moving from superior to inferior in a stepwise fashion. Next, testing for tactile fremitus is performed using the ball of your hand. The patient is instructed to cross her arms and repeat 99 while the doctor is palpating the posterior chest wall for a vibration. The examiner should compare the strength of transmission through the chest wall in symmetrical areas. Respiratory expansion or excursion is the final step of palpation. To perform this test, the hand should be placed flat on the posterior chest at approximately the T10 level. The thumb should be parallel to the spine and the fingers spread flat against the lateral aspect of the chest wall. The hand should be slid slightly medially to raise a small skin fold between the thumbs and spine. The patient is asked to inhale deeply while the doctor observes for the symmetry and amount of movement of the thumbs with regard to the spine. Percussion is performed next. The examiner percusses in the same pattern as was used in palpation. Again, symmetry of percussion sounds should be compared side to side. The second part of the percussive step involves diaphragmatic excursion. This involves finding the level of the diaphragm at maximum inspiration and expiration. Percussion should be started high enough to be above the diaphragm level, approximately T8. The patient is instructed to exhale completely and hold it. The examiner percusses down to the point at which a resonant sound changes to dull. This point is noted, and then the patient is asked to inhale completely and hold it. The examiner now percusses down again to the point where resonance changes to dullness. The difference between these 2 points is the diaphragmatic excursion and should be approximately 5 to 6 centimeters. This again is done bilaterally. Instrumentation is performed with the diaphragm of the stethoscope. The patient is instructed to breathe through her mouth slightly deeper than normal. Again, the same stepwise pattern is used to auscultate while lung sounds are compared side to side. The doctor listens at each site through a complete respiratory cycle. The doctor will be listening for normal breath sounds and abnormal breath sounds such as crackles, wheezing, or rhonchi. Finally, chest expansion is measured. The tape measure is placed around the chest wall at the nipple level in males and just under the axillary in females. Measurements are taken at rest, full inspiration, and full expiration. The difference between maximum inspiration and expiration is between 4 to 6 centimeters. This concludes the posterior thorax exam. Performance of the anterior thorax. The case history and inspection is the same as for the posterior thorax. Palpation consists of assessing tenderness and observable abnormalities. Next, the doctor is testing respiratory expansion on the anterior, placing the thumbs near the midline along the edge of each costal margin with the hands spread laterally across the rib cage. The patient is asked to inhale deeply while the doctor watches for the degree of divergence of the thumbs. The last part of palpation is tactile fremitus. Again, notice symmetrical portions of the chest are being examined in a stepwise fashion. When examining a female, the patient should be asked to gently displace her breasts as necessary to perform the exam. Again, the patient will be instructed to say 99 as the doctor palpates. Percussion is performed next. The examiner percusses in the same pattern as was used during the palpation step. Again, symmetry of percussion sounds should be compared side to side. There is normally an area of dullness on the left side due to the heart location. Instrumentation is next, and the final step of the anterior thorax exam. The diaphragm of the stethoscope is used for this part of the exam. The patient is instructed to breathe through her mouth slightly deeper than normal. Again, the same stepwise pattern is used to auscultate while lung sounds are being compared side to side. The doctor will be listening for normal breath sounds and abnormal breath sounds such as crackles, wheezing, or rhonchi. This concludes the anterior thorax exam. Examination of the heart. When the case history is taken, questions should be asked concerning congenital defects, arrhythmias, murmurs, coronary artery disease, congestive heart failure, angina, myocardial infarction, hypertension, diabetes mellitus, high blood cholesterol or triglycerides, and any history of strokes. The questioning should not only be specific for the patient, but include any family members with known cardiovascular history. The patient should also be asked if he has experienced any chest pains, shortness of breath, exercise intolerance, unusual fatigue, swelling, cough, and increased urination, as well as any medications he may be taking. Inspection will be done next. The doctor will be looking for any abnormal pulsations or heaving on the chest wall or vascular areas of the neck. Inspection should be done with the doctor standing on the right side of the patient and visualizing the chest at an angle to take full advantage of the natural lighting. 6 anatomical landmarks should be observed. Aortic area at the right second intercostal space. The pulmonic area at the left second intercostal space. Erb's point at the third intercostal space. The tricuspid at the left fifth intercostal space at the sternum. The apical area at the left fifth intercostal space at the midclavicular line, and the epigastric area just below the tip of the sternum. Palpation is performed next and is done in 2 stages. The first stage is the palpation of tenderness, swelling, and masses at each of the anatomical areas using the finger pads. The second part of palpation is done to feel for any vibratory sensation at each of the valve areas. The terms thrills and heaves are used to describe any abnormal sensations, thrills being a vibration, while a heave is a forceful pulsation that bounds against the examiner's hand. At this time, note the location and diameter of the apical impulse. An impulse noted larger than 2.5 centimeters or lateral to the midclavicular line is abnormal and possibly a sign of an enlarged heart. The location of the heart borders is determined in the next step, which is percussion. The heart tissue will be dull to percussion amid surrounding resonant lung tissue. The left heart border dullness is usually at or inside the midclavicular line at the fifth intercostal space. In the male patient, the right heart border can be percussed at approximately 3 rib spaces, second, third, and fifth, and always done from lateral to medial. For the left area, the same rib spaces should be percussed from lateral to medial, listening for the change from resonant to dull. Note how far lateral percussion starts. At the second and third rib, it is almost at the anterior axillary line, and at the fifth intercostal space should start at the mid-axillary line. Last, auscultation is performed using the stethoscope. The 5 anatomic areas are auscultated: the aortic valve, the pulmonic valve, Erb's point, tricuspid, and mitral valves. Each area should be auscultated for approximately 15 beats of the heart. Each area should also be auscultating using the bell of the stethoscope for 15 beats and the diaphragm of the stethoscope for an additional 15 beats. The examiner should listen longer at any point where abnormal sounds are heard, enabling her to better characterize the sounds. During auscultation, the doctor will be listening for the S1 and S2 sounds, the rate and rhythm of these sounds, and any splitting of the sounds. The doctor should also listen between the normal heart sounds during systole and diastole for any extra heart sounds such as clicks or snaps and any murmurs. It should be remembered that a position of the patient can aid in the auscultation of various sounds. Having a patient roll partly onto the left side accentuates the S3, S4, and mitral murmurs, while having a patient sit up, lean forward, exhale completely, and stop breathing accentuates aortic murmurs. This concludes the heart exam. We will now be demonstrating the heart exam on a female. A complete case history has been taken. The first part of the exam will be inspection of the same valve areas. Notice how the gown is pulled down to expose the upper intercostal spaces and up to expose the lower spaces. Palpation is done in the same procedure as was performed in the male, noting tenderness and thrills. The same areas will be palpated: the aortic and pulmonic valve area, Erb's point, and the tricuspid and mitral valves. Percussion will be done next. In the female patient, the right heart border should be percussed from the second intercostal space to the sternum, down the right-hand side of the sternum to the fifth intercostal space, and then lateral until reaching dullness of the liver. The female patient should be instructed to cup her breast and displace the breast laterally. For the left area, the same rib spaces should be percussed from lateral to medial, listening for the change from resonant to dull. Note how far lateral percussion starts. At the second and third rib spaces, it starts at the anterior axillary line. At the fifth intercostal space, percussion should start at the mid-axillary line. Auscultation is performed in the same manner as was performed in the male patient. Again, noting that both the diaphragm and the bell both will be used, each for 15 beats at each of the 5 valve areas. Again, in the female, noting that you can do the pulmonic, aortic, and Erb's point, the upper intercostal spaces first, and then go to the lower, the mitral and tricuspid valve after the upper part has been auscultated. This concludes the heart exam on the female. Examination of the abdomen. When obtaining the case history for this system, questions should include inquiries about present abdominal pain, changes in bowel habits, nausea, vomiting, diarrhea, or constipation. Changes in appetite and weight should also be noted. A past history of liver, gallbladder, kidney, or GI diseases, and include other diseases such as hepatitis, cirrhosis, kidney stones or gallstones, colitis, irritable bowel disease, Crohn's disease, pyelonephritis, urinary tract infections, GI bleeding, and cancer. These problems should also be asked about in the family history as well. In obtaining this information, questions can be asked about pain, change in bowel habits, flatulence, nausea and vomiting, any symptoms with the genitourinary system, dysphagia, changes in appetite or weight, and any medications that the patient may be taking. When proceeding to the actual exam, there are 3 essentials to have: good lighting, number 1, 2, a relaxed patient, and 3, full exposure of the abdomen from above the xiphoid process to the symphysis pubis. The first part of this exam starts with a careful inspection, looking for changes in contour, pulsations, masses, skin lesions, and any vascular patterns that may be present. Next, note the change in the hip-urinary order. Auscultation is done next because of it being the least invasive part of the rest of this exam. Using the diaphragm of the stethoscope, auscultate the abdomen in all 4 quadrants. Listen in each of the quadrants for bowel sounds. Normal bowel sounds, which are referred to as clicks and gurgles, occur at a frequency of 5 to 34 per minute. The examiner will also be auscultating for any bruise by placing the bell of the stethoscope over the major vessels, the renal arteries, the aorta, the iliac arteries, and the femoral arteries. Percussion is done next. This consists of several parts. The first part is the percussion of all 4 quadrants, determining the nature of the underlying tissue. Hollow, gas-containing organs will produce hyperresonant or tympanic sounds, and solid or fluid-filled tissues will produce a dull sound. The second step involves percussion of the gastric air bubble in the left upper quadrant. This is found by percussing over this quadrant, the anterior rib cage, and the left epigastric area. The air bubble will produce a tympanic sound. The next part of percussion involves the spleen. This is done in the area of the left 10th rib, just posterior to the mid-axillary line. It should produce a dull sound. Last, percussion of the liver is assessed. This gives the examiner an idea of the size and span of this organ. Percuss upward to the lower edge of the liver from a point just below the umbilicus on the right midclavicular line. Mentally mark the area where dullness begins. Percuss downward to the upper liver edge from an area of resonant lung. Again, mentally mark this area. The difference between the 2 marks will be the span of the liver. The normal liver span is between 6 to 12 centimeters at the midclavicular line. The last part of this exam is palpation, which is done in 2 parts. The first part is light palpation, looking for tenderness, muscle guarding, or rigidity. The second part of palpation is deep palpation. This should be done gently and slowly and using 2 hands. Again, the examiner will note any tenderness, masses, and pulsations. Next, the examiner should palpate the liver edge. The examiner starts palpation below where the liver edge was percussed and asks the patient to inhale. Inhalation will cause the liver to move downward to meet the hand. This step should be repeated while the examining hand is moved successively closer to the costal margin until the liver is palpated. Next, palpate for the edge of the spleen. Unless the spleen is enlarged, this is often not palpable. Next, attempt to palpate each kidney by the capture method. One hand is placed on the back below and parallel to the 12th rib. Lift up with this hand to try to displace the kidney anteriorly. The abdominal hand is placed in the right upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, press deeply to try to capture the kidney between both hands. Ask the patient to breathe out and hold his breath. Slowly release the pressure of the abdominal hand and attempt to feel the kidney as it slides back into position. Repeat the same steps on both sides. Often, normal kidneys are not palpable. Lastly, palpate for the width of the abdominal aorta pulsation. Start laterally and palpate with both hands, moving slowly toward the midline until the pulsation is just palpable with the index finger of each hand. Note the width when both hands are able to palpate this pulsation. The normal width is not more than 3 centimeters wide. This completes the exam of the abdomen. Examination of the lymph nodes. Pertinent case history questions will include local swelling, masses, pain or tenderness in the area of the neck, axilla or groin, edema of an extremity, history of skin infections, cancer or lesions of the mouth, face, extremities, or genitalia. Inspection includes exam of the head, neck, axilla, or groin for masses, skin redness, or discharge. Each area will be inspected individually prior to palpation of the particular region. First, inspection of the cervical region is done, and then palpation of the cervical region follows. This will include exam of the major lymph node group for masses and/or tenderness. This should be done bilaterally. The areas to be palpated in this region are the pre-auricular nodes located in front of the ear, posterior auricular nodes located superficial to the mastoid process, occipital nodes located at the base of the skull, tonsillar nodes located at the angle of the mandible, submandibular nodes located midway between the angle of the jaw and the tip of the mandible, submental nodes located at the midline a few centimeters behind the tip of the mandible, the superficial cervical nodes located superficial and following the sternocleidomastoid, posterior cervical nodes located along the anterior edge of the trapezius, deep cervical chain of nodes located deep to the SCM. Palpate these individually as to avoid bilateral carotid massage. And lastly, the supraclavicular nodes located deep in the angle formed by the clavicle and the SCM. Next, inspection of the nodal regions of the upper extremity should be performed. This will include the axillary region and the epitrochlear region. To palpate the axillary nodes, have the patient seated with arms relaxed at her side. Support the arm to relax the muscles that cross the shoulder joint. To check the central nodes, the examiner places her hand as high in the axilla as possible and inward toward the chest wall and palpates in a downward direction. To check the pectoral or anterior nodes, palpate from superior downward along the anterior aspect of the axilla. To check the lateral node, palpate from superior downward along the inner aspect of the inner upper arm. To check the posterior nodes, palpate from superior downward along the posterior aspect of the axilla. To check the infraclavicular nodes, palpate along the inferior aspect of the clavicle. To check the epitrochlear nodes, palpate superior and medially to the elbow joint with the elbow flexed to about 90 degrees. Again, these areas should be done bilaterally. Lastly, inspection of the inguinal region will be performed. The area will be inspected, and then the nodes of the inguinal region will be palpated. Palpate the horizontal chain along the groin inferior to the inguinal ligament, and palpate the vertical chain along the upper inner thigh. Repeat the same pattern on the opposite side. Commonly, 0.5 centimeters or less, freely mobile nodes are present and normal for this area. Findings that are suspicious for abnormal nodes include nodes that are enlarged to greater than 1 centimeter, matted nodes, hard nodes, tender nodes, persistent enlarged nodes. If any of these present, a follow-up evaluation is necessary. This concludes the exam of the lymph nodes.